In this lecture, we'll cover Chapter 33, Myelodysplastic Syndromes. So your myelodysplastic syndromes are a group of acquired clonal hematological disorders that are characterized by progressive cytopenia in the peripheral blood. So that cytopenia just means that there's a decrease in mature cells. So that's just going to mean that you're going to have more immature cells in circulation in your peripheral blood. And it is actually reflected with defects in the erythroid, myeloid, and the megakaryocytic maturation. The median age for diagnosis is around 76 years old. It's rarely seen in individuals less than 50 unless there is some sort of treatment like chemotherapy or radiation for other neoplasms that has stimulated the course of this disease progression. Cases in young adults and children have been reported, even though it's not very common. If someone has a myelodysplastic syndrome, there is an increased risk for disease progression into an AML, or acute myelocytic leukemia. Now, you can have a percentage of patients that are healthy, but they do have that clonal hematopoiesis, but they never really developed any sort of hematological disorder. And this is known as clonal hematopoiesis of indeterminate potential, or CHIP. Now, if there are complex interactions among additional somatic mutations, epigenetic modifications, a bone marrow microenvironment, or environmental stimuli that can actually determine whether CHIP actually will develop into a myelodysplastic syndrome or any other hematological disease. And so the severity of the subsequent disorder and its risk for transformation into AML are basically based off of anything that may be underlying that can stimulate that disease to progress to an even worse state. The therapeutic-related myelodysplastic syndromes develop in patients after there's been some sort of treatment with the chemotherapy agent. So again, that's seen in that population that's usually less than 50. And then, of course, there are other mutations that have been identified that can increase the risk for myelodysplastic syndrome. There are two morphological findings that are very common to all types of myelodysplastic syndrome, and this will include the presence of progressive cytopenias despite cellular bone marrow and dyspoiesis in one or more of those cell lines. Apoptosis regulates cell population by decreasing cell survival. Now, if there's a disruption of apoptosis, it could be responsible for the ineffective hematopoiesis in myelodysplastic syndromes. So apoptosis, which is programmed cell death, it actually, what it does is it kind of lets the cell know that, hey, you've done your duty, you've done your job, so it's time for some self-destruction. So again, that's just where the cell kind of breaks down, and anything that can be reused is reused by the body, and anything abnormal is going to be removed. Later in the myelodysplastic syndromes, when progression towards leukemia is apparent, apoptosis is actually decreased, which allows an increase in those neoplastic cells to actually survive and expand on by doing that abnormal clone. So as it further divides or replicates, then that abnormality is going to stay present. So in the myelodysplastic syndromes, each of the three major myeloid cell lines actually have some sort of dyspoetic morphological feature, so some sort of abnormal features to them. So we'll discuss these: the dyserythropoiesis, dysmyelopoiesis, and dysmegakaryopoiesis. This is mostly what's just going to kind of lay your foundation of what these morphologies for these myelodysplastic syndromes will actually look like. So dyserythropoiesis, so as the name implies, it is obviously going to affect the red blood cell lineage. Within the peripheral blood, you're going to see things like oval macrocytes, and so these are going to be red blood cells that have that oval shape, but they're a little bit larger than what you would typically expect them to be. You're going to see things like hyperchromic microcytes, and so these are going to be cells that are a little bit smaller than normal, and then that central pallor is actually clearer than normal because you have less of that hemoglobin content within that cell. When you see things like this present, then you need to kind of be aware that you've got to be able to differentiate other diseases that can mimic any sort of myelodysplastic syndrome. So by checking things like vitamin B12, folate values, then that's going to kind of help you rule out any sort of anemia, as well as checking iron stores. These patients will also have a dimorphic red blood cell population. You can also see other things like poikilocytosis, basophilic stippling, Hau-Jolly bodies, and siderocytes. And obviously, if you're seeing the presence of this abnormal red blood cell morphology within the peripheral blood, then it's got to have started somewhere before that point. So the bone marrow is going to kind of help give you an idea of what you're dealing with. So within the bone marrow, you will have evidence of dyserythropoiesis by the presence of red blood cell precursors that will actually have more than one nucleus or some sort of abnormal nuclear type of shape. So you may see cells that actually have a nucleus that has some sort of abnormal shape to it, or you could see some sort of like bud to that nucleus, as well as some sort of fragment within the nucleus of those early erythrocyte cells. You could see the presence of nuclear bridging, so it almost looks like you have two nucleuses that are kind of connected by a little bitty string or a bridge. There may be abnormal cytoplasm features within these cells, including basophilic stippling or heterogeneous staining. You may see ring sideroblasts. This is a common finding. You could have megaloblastoid cellular development. However, the patient may present with a vitamin B12 and folate that is actually normal. And so you could rule out any sort of other anemia and kind of start to include the myelodysplastic syndrome as part of your diagnosis. And your textbook has several of these charts that are really good, that kind of breaks down each of these into what you actually see morphologically on your peripheral blood and bone marrow. So this here is the chart for the dyserythropoiesis, and it just kind of recovers those things that we just talked about. Dysmyelopoiesis, as it suggests in the name, it does affect the myeloid line. So on your peripheral blood smear, if you have white blood cells that are a little bit more basophilic in color for that cytoplasm, so it's a deeper, darker blue than what you would otherwise see in a normal mature white blood cell, then that could indicate a nuclear cytoplasmic asynchrony. So these cells will actually have an abnormal granulation within that cytoplasm, especially within your neutrophils or your myeloid line. And so what you may see will actually be, you can see granules that are larger than normal. You can see cells that have no granulation at all, or you can see cells that just have very little granulation. So when you're looking at your smear and you're trying to decide if it's a good quality smear, then what helps you kind of help identify those cells are those granules. So obviously if the granules aren't there, it's going to make identifying these cells a little bit more difficult. So agranular bands can really be misidentified or misclassified because of this, because you're really trying to look for those, you're looking for those granules to help you identify it to be a neutrophil. So if your cell is lacking those granules, then you could misclassify it into another category. So this is where you've really got to pay attention to the other features like the cytoplasm color or the chromatin of the nucleus. So you've got to really be very aware of all of the features of any cell in order to do proper identification. So in addition to that cytoplasm being abnormal, you can also have abnormal features within that nucleus. So that nucleus can actually be hyposegmented, it could be hypersegmented, so more than 5 of those actual divisions, or it could have nuclear rings. Within the bone marrow, these cells will also have a nuclear cytoplasmic asynchrony. So this could be something like uneven staining with like a dense ring around, or dense ring of that basophilic color that's around the periphery of that cell. But then you have like a clear or unstained area that's left around the nucleus, or you have whole sections of cytoplasm that don't actually stain. But then the remainder of your cytoplasm will actually stain normal. These cells will also have abnormal granulation, so you can actually see within your promyelocytes or myelocytes, or even both, where they don't really have those primary granules. Or those primary granules could be larger than normal, or the secondary granules may be reduced in number, or they can actually be absent altogether. And you could also see an occasional eye rod. So when you actually have the agranular promyelocytes, you can start to mistake these cells for blasts because they do kind of still have that nucleoli, so they still kind of have that look. So when we're kind of deciding if a cell is a promyelocyte, we're definitely looking for the presence of those primary granules. So if those granules aren't present, then it can lead to misclassification of this disease, as far as being able to understand the differences between those cells. You can also have other abnormal nuclear findings that could include something like hypersegmentation or hyposegmentation, and you can also see those ring-shaped nucleus too. Dysmegakaryopoiesis. So obviously this will affect the megakaryocytes or the platelets. In the peripheral blood, you'll actually see a dyspoietic morphology. So you'll see various changes within those platelets to include things like giant platelets or abnormal platelet granulation. So it can those platelets can either have too little of those granulocytes or no granulocytes at all. So you basically see the little colored blob without those little specks of granules in there. Some platelets can have large fused granules, and then those circulating megakaryocytes can be present in peripheral blood with patients that actually have myelodysplastic syndrome. So you can actually see those huge, gigantic early platelet forms actually in the peripheral blood. Now in the bone marrow, those megakaryocytes can actually also show an abnormal morphology. So you can have large mononuclear megakaryocytes, micromegakaryocytes, or micromegakaryoblast. So the nucleoli in these cells may be bilobed, or it can have multiple small separated nucleoli. Now, just because you can tell on a slide that a patient has some sort of dysplasia, that doesn't necessarily mean that you can actually diagnose myelodysplastic syndrome, because there are several other conditions that have very similar features, so you need to make sure that you rule those out. So for example, anemias or copper deficiencies or some sort of drug or chemical cause of that particular dysmorphic morphology. So diagnosis of a myelodysplastic syndrome actually is like a multi-tiered thing. So you've got to include a combination of the patient's history, making sure they've not been exposed to any kind of drugs or chemicals. It could be through their employment or things around the house, whatever. And you also got to take that component into consideration with their physical examination, how they're physically presenting, as well as any sort of laboratory data that you can kind of use to correlate, to rule out things or to rule certain conditions in or out. Now, if you have cells that are produced because there's some sort of abnormality in that maturation and they start giving that appearance that they're abnormal, then they're also going to probably have some sort of abnormal function to them as well. So for your granulocytes, you can have decreased adhesion, you can have deficient phagocytosis, so they're not able to go and find those foreign elements like bacteria or anything like that and actually ingest it and take care of it for you. Or you can have decreased chemostasis or an impaired microbial capacity. So in other words, those cells aren't able to fight off any sort of infection like they typically should be able to do. So this is going to mean that there's some sort of decreased level of that myeloperoxidase or alkaline phosphate in those cells that kind of aids with the function of that cell. Now your red blood cells can exhibit a shortened survival. Your erythroid precursors can have a decreased response to EPO. Then because of that response being decreased to that EPO, then that's going to contribute to an anemia. Your patients could experience an increased bleeding despite there being an adequate number of platelets. Even though you have plenty of platelets, if they're not functioning the way they're supposed to, then that's obviously going to create issues for that patient. So basically the type and the degree of the dysfunction that you're going to see in your myelodysplastic syndromes is going to be dependent on the particular mutation that's present in the particular hematopoietic stem cell. So back to these wonderful classifications for these disorders. Again, you have the French American British classification. And of course, this one classifies it into 5 of the myelodysplastic syndromes. Each one has a specific set of morphological criteria that's tied to it. And the categories are structured by the amount of dysplasia and the number of blasts that are actually in the bone marrow. The diagnosis of acute leukemia requires at least 30% blasts in the bone marrow. So the FAB, here you can see the listing of the FAB classifications. Again, this particular classification is not used much anymore, but you may still have, you may still hear things referred to it. So we do still list that, but it's kind of being phased out. So the WHO classification kind of was initiated based off of that FAB classification system. They have kind of piggyback off of that and made some modifications and changes within the classification system. So WHO classifies dysplasia in order to be able to diagnose myelodysplastic syndrome, to say that you need at least 10% dysplastic cells in any of the hemopoietic lineages. Now, WHO actually uses this system based off of the morphological, molecular, cytogenetic, and immunological characteristics of those blood cell lines in order to differentiate which category to place that myelodysplastic syndrome within. Here we've got another one of those charts that just kind of spells out exactly what that WHO classification system is. Your textbook also has a great chart that kind of lets you know, based off of those WHO classification systems, how each of those different myelodysplastic syndromes will actually present with your peripheral blood findings as well as your bone marrow findings. It's a great chart. It's not a bad idea to kind of keep this as a quick reference. So the myelodysplastic syndromes and the myeloproliferative neoplasms. So this category actually includes the myeloid neoplasms with clinical, laboratory, and morphological features that are classic to both of these disorders. Included in this classification is the chronic myelomonocytic leukemia, atypical chronic myeloid leukemia, juvenile myelomonocytic leukemia, refractory anemia with ring sideroblasts and thrombocytosis, and the myelodysplastic syndrome and myeloproliferative neoplasm that is unclassified. Chronic myelomonocytic leukemia. So again, as the name implies, you're going to have issues with those monocytes. So you're going to have persistent monocytosis with more than 1.0 monocytes to be present. You will have an absence of the BCR ABL1 fusion gene, or you can have a rearrangement that involves the PDGFRA, PDGFRB, FGFR1, or PCM1 JAK2. You can have less than 20% blast and promonocytes in the peripheral blood and within the bone marrow. You can also have dysplasia in one or more of those myeloid cell lines. Now, even if dysplasia is not present, you can still make a CMML diagnosis, because if you have the presence of unexplained monocytosis that persists more than 3 months, or you have cytogenetics or molecular mutations that's consistent with this, then you can still make that diagnosis. Now, the mutations that can take place is very complex, and some patients can actually have 8 to 14 distinct mutations that are present. Now, more than 90% of CMML cases actually do have some sort of mutation. The most common mutations are listed here. The cytogenetic abnormalities that can also be present include things like trisomy 8, as well as the loss of all or portions of chromosome 7 are very common as well. To have leukocytosis and dysgranulopoiesis is often evident, and the patient can have splenomegaly, and this is going to be due to an infiltration of those leukemic cells that are going to be present within that spleen. There are 3 subgroups of chronic myelomonocytic leukemia that are recognized by WHO, and those are going to be based off of the blast percentage, and of course that's going to kind of have a little bit of a factor in the survival of those patients. So here we have them listed with CMML 0 with less than 2% blast in the peripheral blood and 5% within the bone marrow. The grade 2 has 2 to 4% blast in peripheral blood with 5 to 9% in the bone marrow. And then the that was grade 1, and then grade 2 will have the worst prognosis with 5 to 9% blast in the peripheral blood and 10 to 19% in the bone marrow. So as you can see, the higher that blast count, whether obviously if it's a higher in the bone marrow, it's going to be higher in the peripheral blood, but the higher that blast count gets, the worse the prognosis is for that patient. A typical chronic myeloid leukemia that is BCR-ABL1 negative. This is characterized by leukocytosis and morphologically dysplastic neutrophils, and any of the precursors of those neutrophils, so those early cell lines. Basophilia may be present, but is not a prominent feature of these cells. You can have multilineage dysplasia. Now, while that BCR ABL1 fusion gene isn't present, you can have karyotype abnormalities in about 1/3 of the patient population, with essentially all patients demonstrating at least one gene mutation of some sort. Now, dyspoiesis may be seen in all of the cell lines, but the most notable one is going to be the neutrophils, and these neutrophils can actually exhibit Pale-Goulet-like cells. They can have hypergranular, or they can have these weird shaped segments to them. The prognosis for these patients that have the acute chronic myeloid leukemia is very poor, because it typically will actually progress to an acute myeloid leukemia, and then the patients will eventually succumb to the fact that they start having a bone marrow failure, producing those normal cells. Juvenile myelomonocytic leukemia. This is a clonal disorder that is characterized by the proliferation of granulocytes and the monocytic cell line. It affects children from about the ages of 1 month to 14 years of age. Most of these patients have some sort of somatic or germline mutation that will actually activate the RAS-MAPK pathway. There is a strong association with congenital diseases, and an allogenic stem cell transplant is effective in about 50% of these patients. Myelodysplastic syndrome, myeloproliferative neoplasm with ring sideroblasts and thrombocytosis. So this was once known as to be a refractory anemia with ring sideroblasts and thrombocytosis. However, the WHO has since changed that classification. Um, this disease has often been associated with mutations of the SF3B1 and the JAK2 V617F mutation. It does present as an anemia. It has about 15% or more of ringed sideroblasts, thrombocytosis, atypical megakaryocytes, and about 1% or less of blasts will actually be present in peripheral blood, with 5% or less present in the bone marrow. Myelodysplastic syndromes, myeloproliferative neoplasms, unclassified. So this is actually used for cases that meet the criteria for both of these, but they don't really fit into one of the previously mentioned subcategories. So the time of diagnosis, the clinical history, the detection of a molecular abnormalities are important factors in being able to actually diagnose what particular condition it is. So basically, once you've ruled everything out, but you still feel like it's in, and when I say you, I mean the physician, we as in general, healthcare, once you've kind of ruled everything else out, then, and you feel like it's still in the myelodysplastic, myeloproliferative neoplasm category, then basically ruling everything else out is what brings you to this classification. So again, as technologies advance and we start to learn what causes some of these and start to kind of uncover some of those mysteries out there, then you can in the future see some of these things kind of be reclassified again. So with chromosomal abnormalities, about 50% of the cases that you will see for myelodysplastic syndromes are going to be for really no known cause. Nobody really knows what the cause of it is, so the de novo. About 90 to 95% of them are actually going to be some sort of therapy-related myelodysplastic syndrome. So karyotyping is actually, it actually has a major effect on the prognosis of the myelodysplastic syndrome patients, and this specific karyotype can actually be used to continuously predict the response to treatment. So cytogenetics will actually be used to figure out which chromosomal abnormality is present so that it can better gauge the prognosis as well as treatment for these patients. Now, epigenetics actually describes the changes in a gene expression that happen without actually altering the DNA sequence. Instead, the gene function is actually affected through selective activation or inactivation rather than an actual change in the primary nucleotide sequence itself. Now, by using some of the more advanced molecular genetic testing, it does allow for being able to better determine that prognosis. So being able to identify the specific genetic defect can actually help with some of the more recent targeted therapies that target specific things versus trying to, essentially, place a whole batch of poison into a patient to try to correct some of these mutations or to kill off these abnormal cells. By looking at it from a molecular standpoint, we can kind of be more targeted, specific with the therapies. About 90% of patients that have myelodysplastic syndrome will have at least one mutation. And some patients can actually have more mutations than that, multiple mutations. Some of the most common mutations are listed here. Now, the prognosis value for these gene mutations can vary, so it's just basically going to depend on the specific diagnosis for the patient and whether or not that disease has a likelihood to kind of progress on to something like an acute myeloid leukemia. So again, just to reiterate, for any of the myelodysplastic syndromes, basically any kind of neoplasm, prognosis is going to be dependent on several different things, including the percentage of bone marrow blasts that are present, the depth of cytopenia, and the karyotype that is present, the abnormalities that are actually present. So the WHO classification system actually uses the similarities in morphology, molecular, genetic, immunological, clinical characteristics, just to kind of help with that prognosis. But there are other prognostic scoring models that are out there. So those are listed here, some of the other ones that are out there. So basically, treatment for the myelodysplastic syndrome depends on the prognosis. If the prognosis is favorable, patients may just get supportive type therapy. However, if prognosis, demonstrates a more aggressive outcome, then obviously the type of treatment or therapy that's used is going to be ramped up a little bit. There are a variety of treatment options available to patients, and again, it's just going to depend on what the prognosis is. It can include things with just a supporting quality of life, providing supportive care, providing transfusions, EPO, prophylactic type of treatments, all the way up through stem cell transplants or medications and different things like that. So there are options out there for treatment, and again, it's just going to kind of basically depend on the patient prognosis.